Dear colleagues, it's my great pleasure to host this e-seminars ERA Journal Club on the topic efficacy and safety of hypoxia-inducible factor Prolyl Hydroxylase inhibitors in patients with chronic kidney disease, a meta-analysis of phase 3 randomized controlled trials. And it's our pleasure to welcome the author of this publication, recently accepted in the Clinical Kidney Journal, Professor Roberto Minutolo from the University of Naples, University of Campania, Luigi Vanvitelli. He's an associate professor and works at the Department of Medical Science and Advanced Surgery. It's also my great pleasure to welcome our panelists. First, Lucia del Vecchio, a nephrologist and senior researcher at the Department of Nephrology and Dialysis in Como, Italy, and Evi Nagler, who is a nephrologist at the department at the Transplant Center of Ghent University Hospital in Belgium, with an expertise in meta-analysis and complex statistical analysis. I'm moderating this together with my colleague and friend Amaryllis van Craenenbroeck from Leuven, Belgium, who has been the past chair of the YMP. And my name is Andreas Kronbichler from Innsbruck, Austria.
Okay, good afternoon to everyone. First of all, let me thank the committee who selected our paper for this journal club. These are my disclosures. Okay, the new strategies for anemia treatment is represented by drugs acting on hypoxia-inducible factor pathway. At normal oxygen levels, the if pathway is not activated. The enzyme Prolyl Hydroxylase, in fact, in the presence of oxygen, is fully active. It induces the hydroxylation of subunit if alpha, and this hydroxylation represents the signal for continuous degradation of subunit alpha. On the contrary, during the hypoxia, if Prolyl hydroxylase is inactive because oxygen is required for its enzymatic reaction, and therefore if alpha accumulates in the cell, translocates into the nucleus and dimerizes with the subunit if beta. The complex if alpha if beta activates gene transcription for erythropoiesis and iron metabolism. If Prolyl hydroxylase inhibitors are the small drugs that acts by reversibly inhibiting if Prolyl hydroxylase enzymes and stabilizes if alpha under normal oxygen condition, thus mimicking the physiologic response of body to hypoxia. Initial phase 2 studies have provided promising results on the AKB increase, hemoglobin increase, and on hepcidin reduction in dialysis and non-dialysis patients. However, concern have been raised on safety of this drug because the activation of pathway is involved in the control of multiple biological processes, including cell proliferation, angiogenesis, and tumor growth. So far, the efficacy and safety of 6 IF-PHIs has been evaluated in a 52 randomized trial, about 32,000 CKD patients. Of these trials, 6 were phase 2 studies, 14 trials were placebo-controlled, and 32 trials were phase 3 studies. Several meta-analyses have shown that if Prolyl hydroxylase are effective and safe for treatment of CKD-related anemia. However, this previous meta-analysis have some limitation. The studies selected were heterogeneous by including placebo and ESA-controlled trial, by including phase 2 and phase 3 trial. And in addition, some meta-analysis focused on only one single IF-PHI, particular roxadustat. Other estimated the effects only in dialysis or non-dialysis CKD separately, and some other focus exclusively on safety without considering efficacy measures. In the present meta-analysis, we only included phase 3 randomized trials. ESA controlled, so there was an active control, and with available data on both efficacy and safety. As a further inclusion criteria, we selected studies with the duration of at least 24 weeks, as we deemed that this was a time sufficient to evaluate anemia correction. This selection process leads to retrieve 26 trial with more than 24,000 participants. Our aim was to evaluate the efficacy and the safety of PHIs in comparison with ESA in adult patients with non-dialysis and dialysis CKD. This is an overview of a study selected. It's quite impossible to read in this slide. So I synthesized the characteristics of the studies in this table. 10 studies were carried out in non-dialysis population, accounting for 21% of participants. 3 studies enrolled as naive patients, 17 studies enrolled patients ESA treated, and 6 trials included mixed population. 19 studies were done with either roxadustat, daprodustat, or vadadustat, and the sum of this trial included more than 90% of participants in our meta-analysis. The control group received more frequently long-acting ESA, darbepoetin, or SIRA, and the last point relates to the duration. Among the selected studies, 8 trials at the duration between 24-27 weeks, 11 lasted 1 year, and the remaining 7 had a follow-up between 2 and 3 years. This slide reports the 2 primary efficacy outcomes. Changes of baseline hemoglobin level on the left was significantly higher with the PHIs, but the entity of this increase, as you can see on the top, was only 0.1 gram per deciliter. And of course, the clinical relevance of these increases very little. When looking at the achievement of hemoglobin target as efficacy outcome, the graph on the right, you can see there was no difference between PHI and ESA comparators. Since heterogeneity in both analysis was high, we performed a meta-regression and moderator analysis. At the meta-regression, we found that the hemoglobin change with PHI was greater in younger patients. Other factors as continuous variable here indicated, proportion of female, diabetes, iron repletion, GFR, systolic blood pressure, had no role on heterogeneity. Factors we considered as moderators were the following. We included in the different analysis the type of ESA comparator, long-acting or short-acting, the dialytic stage, the type of PHI used in the trial, the previous ESA treatment, study duration, and the number of participants per arm. We found type of ESA comparator was a significant factor explaining the high heterogeneity. Indeed, the hemoglobin change from baseline was greater, and the target was more frequently reached in PHI when compared with short-acting ESA. Also, the type of IFPHI influenced the heterogeneity about achievement of target, with higher probability of reaching the target in patients receiving desidustat, roxadustat, and daprodustat. One distinctive characteristic of this new class of drug is their ability in coordinating endogenous erythropoietin production with the iron metabolism. Therefore, as a secondary measure of efficacy, we evaluated the changes of main iron parameters. As expected, on the basis of a mechanism of action, IFPHI in comparison with ESA induced a larger decrease in hepcidin and a larger decrease in ferritin and a significant increase of transferrin and serum iron without affecting transferrin saturation. During the revision process, one reviewer raised a very interesting point by suggesting us to evaluate the association between the reduction in hepcidin level and the different increase in AKB level, in order to differentiate if the effect of IFPHIs on hepcidin values was related to the hemoglobin increase or directly induced by this drug. According with this comment, we performed two meta-regressions. In the panel A, we evaluated the effect of hemoglobin change from baseline plotted against the hepcidin changes from baseline between IFPHI and this comparator. The same analysis was repeated only in IFPHI arms, and it is shown in the panel B. These results demonstrated that hepcidin decline with the IFPHI is a direct effect not mediated by hemoglobin response. Finally, we also evaluated the effect of IFPHI in reducing the intravenous iron need. You can see a significant reduction in intravenous iron dosing occurred in patients receiving new drugs in comparison with the standard therapy. However, this difference was very small, was only 3 milligrams per week of intravenous iron. And therefore, despite significant, it cannot be considered as clinically relevant. Interestingly, at a moderator analysis, we found that the heterogeneity in this meta-analysis on intravenous iron was significantly explained by previous therapy, and therefore you can see in the graph that it was higher in ESA-naive patients, and also by the type of IFPHI with a larger effect in studies testing roxadustat. In terms of safety, our meta-analysis does not disclose any alarming signal. Indeed, for cardiovascular endpoints, the risk of MACE and MACE plus were not increased in IFPHI in comparison with ESA. Similarly, the relative risk of deep vein thrombosis or pulmonary embolism, as well as for vascular access thrombosis, was similar between IFPHI and ESA comparator. And finally, the effect of IFPHIs on the risk of cancer and all-cause mortality, which were reported in a larger number of trials, did not differ in comparison with the ESA arms. Particularly related to the two latter points, cancer and mortality, it is important, I think, to underline a limitation of our meta-analysis that is related to the duration of follow-up in the single trials. Indeed, when considering that about half of studies had a follow-up limited to 1 year, we cannot exclude with certainty an impact of new drugs on those adverse events requiring a longer follow-up to occur. As an example, cancer, death, and possibly cardiovascular event. The main strength of our meta-analysis is the exclusion of placebo-controlled studies and the exclusion of phase 2 trial, because this allows, we believe, a more reliable comparison of efficacy and safety between IF-PHIs and ESA. Therefore, in conclusion, this meta-analysis provides evidence that hemoglobin changes obtained with the IF-PHI is slightly higher in comparison with ESA and more evident in younger patients and when the new drugs are compared with the short-acting ESA. However, despite significant, this difference seems not clinically meaningful, as also indicated by the similar rate of hemoglobin target achievement. Overall, an improvement of iron metabolism becomes evident with the IF-PHIs compared with ESA, as testified by a significant decline of hepcidin and ferritin levels, a significant increase in serum iron, and total iron binding capacity. However, these positive effects of IF-PHI on iron metabolism did not translate in a clinically relevant dose reduction of intravenous iron. The risk of major adverse events with IF-PHI is similar to that estimated with ESA therapy. However, I think that long-term surveillance and from post-marketing data are of paramount importance to definitively confirm the lack of safety signal with the IF-PHIs. Thank you very much for your attention.
Thank you very much, Professor Minutolo, for providing this very nice overview of this recent meta-analysis, which is, of course, the highest level of evidence, as we get taught in high school and university, that you can use for improving the guidelines, for example. So I would like to give the word maybe to Professor Evi Nagler from Ghent University as an expert in meta-analysis, to see whether this is methodologically sound and whether there are still questions left.
Okay, hi, thank you, Roberto, and thank you, Amaryllis. Thank you for sharing that study and delivering an intriguing presentation. It certainly provides ample material for a lively debate, I think. So my first question is around the meta-analysis methodology. I'm a bit of a geek when it comes to methodology, I must warn the audience. And so I'm curious about your approach to the meta-analysis. If referring back to slide 10, you use an odds, perhaps it would be good to show that, but if you use an odds ratio for the analysis of hemoglobin target achievement, but then for many of the other dichotomous outcomes, you use a risk ratio. And so I was wondering where that choice came from, what drove that decision, and whether you could share some insights on when you would use either an odds ratio or when you would use a risk ratio for your meta-analytical purposes.
So the odds ratio for target achievement was chosen because the large majority of trials reported the achievement of target in the same time period. So it was, if I remember, between 24 and 36 weeks. So in this period, they provide us the number of patients at target. And so we did this odds ratio. That was the ratio between the probability of being in target between the two groups, IF-PHI versus ESA. For the relative risk about mortality, this was essentially chosen because the large majority of studies report the studies in this way, the results in this way. In a lower number of trials, authors also reported the hazard ratio in terms of risk, and we also meta-analyzed these results for MACE, MACE plus, and all-cause mortality. And we found exactly the same findings that with the data reported as relative risk.
Okay, that makes sense. I can perhaps ask you another question, Amaryllis?
Yeah, sure.
Yes, sure. Yes, go ahead.
Okay.
Yeah.
So my second question is around the interpretation of the outcome. So your conclusion suggests that the hemoglobin change that we see with HIF-PHIs is marginally superior when compared to ESA. Now, what I value in systematic reviews particularly is the ability to interpret the overarching effect estimate in light of the credibility of the contributing studies. And you didn't touch upon that in your presentation, but does your conclusion account for the potential biases present in the underlying studies? My reason for asking that comes from a Cochrane systematic review that was published in 2022, which included an assessment of HIF-PHIs versus ESA. And their findings indicated a substantial risk of both performance and detection bias in over half of the studies due to inadequate blinding. And you know, that significantly affected their confidence in the results. And so you haven't mentioned this, and for that I'd like to pose a deliberately provocative stance here, which is, you know, considering the minimal observed difference and the existing risk of bias, I'm inclined to believe that HIF-PHIs might not be any more effective at all in elevating hemoglobin than ESAs. And I'd love to hear your perspective on that.
So, of course, we assess all the possible risk of bias by using different tests were not significant. We have a difference in terms of hemoglobin increase in HIF-PHI versus ESA as compared with the Cochrane meta-analysis, essentially because Cochrane meta-analysis also included placebo-controlled trials. And so when you compare the HIF-PHI with the placebo, of course, the difference of hemoglobin is larger. And when you put some more data on this way, you may have a larger, to better say, an overestimation of the effect of HIF-PHI in comparison with the control, when in the control is also included placebo. So the lower the strict difference, the lower difference between the drugs in our meta-analysis, I think it depends on the fact that we only included the active control trial. So all the control group included as a treatment and not placebo. The short and not relevant increase of hemoglobin is also testified by the fact that there was no difference in terms of odds ratio in target achievement. So it's so small that you cannot change a target that usually in the large majority of the trials was set between 10 and 12. So if PHI, you reach 11.1, and with ESA 11, of course, the target will not be different.
Okay, thank you so much. I think this largely meets Evi's curiosity here. I'm wondering whether we have some practical questions also, like, for example, we see that the difference is bigger in younger patients. What's your take on this, or maybe the vision of Professor Vecchio?
One of my question was exactly what is the possible interpretation why the inhibitors looks more effective at the dose used for comparison compared to ESA in younger patients than older ones.
This is a very interesting question because we can also make some hypotheses. I don't have a correct answer. I can imagine, I can hypothesize that younger patients may respond better to HIF-PHIs because maybe there is possibly a higher burden of inflammation in younger than in older patients. because younger patients usually more frequently, as an example, glomerulonephritis or initial diabetic nephropathy. And so this may be a possible explanation. As a further possible explanation is on the opposite, that it's not the young patient that is go better, but it's the old patients that it worse, because possibly there is a larger myelofibrosis in older age that induce a less response of in terms of red blood cells production when the bone marrow is stimulated.
In
your opinion, we could say that older patient needs higher hemoglobin poietin levels to obtain erythropoiesis. So if you give them ESA, probably they achieve better, let's say, hemoglobin levels than with inhibitors that stimulate just over physiological EPO level.
Yeah, this is an hypothesis also. Absolutely agree with you.
I see we have another question from Evi.
No, I just wanted to add, could I be the irritating skeptic here and say that given that you conducted multiple meta-regressions and sub-analyses, I think it was 12 in total, and considering the potential for type 1 error inflation from numerous comparisons, could that just be a false positive correlation?
Maybe, yeah, no, you're absolutely right. This was a point raised by our, so I expressed to our epidemiologist, and they said that essentially there was a problem with this association in which the p-value was relatively low. As an example, with the moderator analysis on intravenous iron use, in which the type of IFPHI or the previous ESA use were relatively small, 0.04, 0.03. So in this case, you may have an inflation, so this is not really significant, confidently significant. But the other that we found were well below 0.001. So also, if you consider also considering the multiple comparison, it should be reasonably remain significant.
May I continue with some questions from the chat? We have received a couple of them. So one was actually related to the differences between long-acting and short-acting ESAs. Do you think that there has been basically a dose difference, that you see this significant difference between both administration routes?
No, I mean, I think that there is a strong influence on the dose frequency of a short-acting ESA. So if you use the short-acting ESA at a longer interval, you have a less efficacy in comparison with the 2 or 3 times per week administration. And this is something that we testified to in a paper some years ago, but also 30 years ago has been demonstrated by Tony Besarab in a small trial. The problem is that in the large majority of trials where this information is reported, because it's not always reported, short-acting ESA, poietin alpha, was used every 1 week. And of course, this is less effective in terms of anemia correction, and this may explain the difference we found.
And do you know that, or if HIF-PHIs do have an anti-inflammatory effect?
There is a significant reduction in hepcidin, and it seems to be a direct effect. So this, of course, hepcidin is the critical protein, the key regulator of iron metabolism. that is increased during inflammation. So I don't believe here that with the IFPHI you reduce the CRP levels, but you may reduce the hepcidin. So the effector affecting the reducing the mobilization of iron from ferritin.
So we have a couple of critical questions. So one is the Dolomite study, for the audience, that's a CKD study, not on dialysis, showed a higher rate of infectious events in the roxadustat arm. These data have raised significant concerns about safety regarding susceptibility to infection. Could you please tell us why these events were not evaluated in your meta-analysis?
Essentially, were not evaluated because there were very, very few studies reporting these. I think there was the Dolomites and one more study. The Dolomites, I don't remember if it was significant, it was higher, but not significant. And the problem of infection with roxadustat has been essentially raised when the pooled analysis with placebo-controlled studies have been evaluated. In that case, you have an increase of infection, but in comparison, not with ISA, in comparison with the placebo trial.
Another one, a very long one again, with the decline in ferritin levels observed during treatment, won't nephrologists be tempted to supplement patients with an excess iron to prevent true iron deficiency and comply with current guidelines? And should there be different recommendations for target ferritin and transferrin saturation levels in patients treated with HIF-PHIs and in those treated with ESAs?
So I will start from second question. So there is no difference. Also, when you administer the IFPHI, patients must be have the iron stores well represented. So it must have a ferritin above 100 if not in dialysis, above 200 or 300 if on dialysis. This is important because one of the effects on iron metabolism of this drug is to mobilize iron stores. So if your patient doesn't have stores, you will not mobilize nothing. So it's important that patients has a correction of eventual iron deficiency. After, what will be interesting in looking in clinical practice will be if I can, with this drug, use less iron. I don't believe that we can absolutely avoid iron supplementation. But if you need less iron, I think this is also a very intriguing result. And this is something that has been also reported by roxadustat in the Dolomites trial, in which there was a reduction also in oral iron supplementation, not only intravenous.
Another one is, oh, sorry, Amaryllis, go ahead.
Maybe we should go to a very practical question on safety. So would you use HIF inhibitors in patients with active cancer and anemia?
No.
Are you convinced?
No. Okay. No, because I don't use the ISA neither.
Neither. So you would
our oncologist colleagues suggest to use this drug only during the chemotherapy to counteract anemia due to chemotherapy, and not to counteract chronic anemia of patients with cancer. So if I don't use ISA, I will not use IFPHIs.
Okay, very clear. And on another safety level, we have a critical question on cardiovascular risk. So it's a very long question, actually. So which studies should we trust the results of your meta-analysis regarding the cardiovascular safety and all-cause mortality in dialysis patients, or the findings from the Pyrenees studies and certain subgroups of patients from the Rockies and Sierra studies, which showed an increase in cardiovascular risk unfavorable to HIF inhibitors? What's your take on this?
I think that in the Sierra there was a slight increase in the cardiovascular risk. In this case, we pulled together all the possible trials with all the available trial comparing not only roxadustat but also other studies. So I think that it's important to remember that a large majority of this trial do not have a sufficiently long follow-up. And so I think that there is a problem of exposure to active drug and ESA that should be not sufficiently compared. And at the same time, I think that larger numbers of observation are required. So this is because at the end of my presentation, I said that long-term surveillance and post-marketing studies are very, very important.
I think this has also been touched upon in the KDIGO conference document, which has just been released, so that the cardiovascular risk is not increased using these drugs. But there's been another question in the box, and very short one this time. Use of these drugs in cardiac patients. I think this is pretty much what we have already answered, but would you use it in a cardiac high-risk patient similar to an ESA?
Well, good question. It depends on the cardiac patients. What do you mean for cardiac patients? Because in patients with heart failure, the ESA trial have been negative. And so they did not provide an improvement in the outcome in the RED-HF trial for patients with heart failure receiving darbepoetin. The difference with the IFPHI that may also be intriguing, but of course require to be tested in clinical practice, is that patients with heart failure usually have a problem related to the functional iron deficiency. So they cannot mobilize sufficiently their iron stores. On this regard, this drug that acts at variance with ESA also on iron metabolism may potentially be useful. But I think that we should test in such a population.
So there has been a practical question. Is there a chance that we see IV formulation for these drugs at some point, or will it remain bare oral?
No, I think that remain oral also because the oral represents potential improvement in iron therapy. So there are patients who don't like make self-injected needle phobia, or patients in which the frequently traveling who required, ESA require the keep of iron cold cold chain, and with oral treatment, you don't have this kind of problem. On the other side, there is a problem of adherence, but this is also something that we will assess in our clinical practice.
We have another question in the chat regarding copper levels. Do we have any idea how this medication influences copper levels?
There is something, I think, mainly as experimental studies, in which there is a reduction in the copper level, but which is the clinical relevance of this effect, I don't know. Okay. I say the truth.
Okay. There's also a question about the difference in iron between the groups, and it states that if both increases the red blood cell production, it should be similar, and if inhibitors increase red blood cell production, more iron is used. So how do you explain the difference? But I think you already did in your previous answers. Or do you want to add something?
Because the hypothetical, the theoretical advantage with this new drug in terms of iron supplementation is that you can mobilize better the iron that is stored in the ferritin. and therefore, if you have a better mobilization of iron store, of course, you will require less intravenous iron. A further advantage of this drug is that there is also an improvement in the iron absorption, intestinal iron absorption. And so in this way, you possibly this drug may make more effective oral treatment, or alternatively, they can allow the use of oral iron at a lower dose, and in this way to reduce the gastrointestinal side effects.
Thank you. I think we are running out of time a bit, and I just would like to ask you, the panel, if there would be more questions or any burning questions from the audience. Okay. My final question to you, Professor Minutolo, would be whether you are convinced to switch your patients to HIF inhibitors, or in which cases you prescribe them to your patients.
So I think that my ideal candidate to the IFPHI is as an naive patients, and preferably those not on dialysis.
Okay.
This because I think that you may have the best advantage in terms of results and advantage for patients, practical advantage for patients.
Okay. So with this, I think we can close this journal club, and we warmly invite you to the next journal club of ERA, which will be Monday, the 23rd of October at 5 p.m. It will be Hedo Heerspink speaking about the efficacy and safety of sibotentan and dapagliflozin in patients with CKD. It will be the study design and baseline characteristics of the Zenith CKD trial. So warmly welcome. We hope to see you there, and see you next time. And again, thank you very much to our speakers and to the panelists of this journal club.